Let's talk about the pupil, the small black circle at the center of your eye. It acts like a camera aperture, adjusting to control how much light enters. In bright light, your pupil constricts to protect your eye. In darkness, it dilates to let more light in. This automatic adjustment is called the pupillary reaction. When a doctor shines a torch in your eye, they're checking this reflex to assess both eye and brain health. Light in one eye causes both pupils to constrict, showing the nerve pathways are working together. Any abnormal reaction can signal a problem along these pathways. So, when a doctor checks your pupils, they're getting vital clues about your nervous system. That tiny black dot reveals a surprising amount about your overall health. What if the light reflex doesn't work properly in one eye? That's called a relative afferent pupillary defect, or RAPD. RAPD means the optic nerve or retina in one eye isn't sending a strong signal to the brain. Causes include optic neuritis, retinal artery or vein occlusion, or a large retinal detachment. To test for RAPD, doctors use the swinging flashlight test, moving a light between both eyes. In a healthy person, both pupils stay constricted as the light moves. But with RAPD, both pupils dilate when the light hits the affected eye, as if the light got dimmer. RAPD points to nerve or retina damage, not just something blocking light like a cataract. It's a simple test that can reveal serious problems. Now let's look at efferent pathway problems. When the brain's signal to the pupil muscle is disrupted, Adie's pupil is one example. The pupil is large and reacts slowly to light, often harmless. The Argyll-Robertson pupil, linked to late-stage syphilis, doesn't react to light but does constrict when focusing on near objects. Third nerve palsy is more serious. The affected pupil is fixed and dilated, often with a droopy eyelid and the eye pointing down and out. This is a medical emergency. Horner's syndrome is the opposite. The pupil is small and doesn't dilate well in the dark, often with a slight droopy eyelid. These signs help doctors localize where the problem is: eye, nerve, or brain. Each abnormality tells a different story about what's happening in the nervous system. Recognizing these patterns is crucial for diagnosis. That's why pupil checks are so important in neurology and ophthalmology. The eyes really are windows to the brain. Pupils can change size for many reasons, not just disease. Eye doctors use dilating drops to widen pupils for exams. Opiate drugs cause pinpoint pupils, while some brain injuries can do the same. In emergencies, pupil size can help diagnose overdoses or brain damage. Brainstem injuries can cause fixed, pinpoint, or dilated pupils, depending on the location. In intensive care, changes in pupil size can be the first sign of dangerous brain swelling. Monitoring pupils is a vital part of emergency and critical care. Sometimes a quick look at the eyes can save a life. The humble torch test is a powerful diagnostic tool. By checking how pupils react, doctors can quickly tell if a problem is in the eye, the nerves, or the brain. For example, RAPD points to optic nerve or retina issues. A fixed, dilated pupil with eye movement problems suggests a third nerve palsy. Comparing both eyes is key. Always check direct and consensual responses. The swinging flashlight test uncovers subtle differences that might otherwise be missed. This simple exam helps doctors triage and diagnose, sometimes in life or death situations. Never underestimate the value of this basic clinical skill. Sometimes, the simplest tests reveal the most important answers.